Perhaps you've taken care of young kids before and they run up to you screaming and crying and you're wondering what the heck is wrong with you? And then you wonder what the heck is wrong with my head? I've got this splitting headache. And then your grandma walks into the room and starts telling you about her weird fungus that won't go away. I have really good news for you in those situations. You are all pathophysiologists. Hey everybody, Organized Biology here, where we make difficult biology concepts simple. And if you're a nursing student going into this class, or if you're just interested in your body and disease and how it works, you are in the right place. You see, instead of just going through all these words and definitions that you likely will see in a class, I'm instead going to give you stories, and I'm going to give you case studies, and I'm going to go through questions that will be answered in those classes, or maybe questions that you want answered in your own life. So before we get into this complex subject, I want to point out two words first. So pathology and our friendly pathophysiology. You can notice there is a common prefix and suffix in both of them because words matter in anatomy and physiology. So in patho, we are looking at something that means suffering. It's actually an old Greek term meaning suffering. So whenever we say patho in anatomy physiology, we're talking about disease. So suffering, we're going to say, is some sort of disease. So in both of these, we've got disease. But then we've got the ology, right? And that's going to just mean the study of something. Now, we're studying disease in both of them, right? But then what's the difference? This physio in between. Physio refers to nature or function, okay? So I'm going to use the word function for this because where pathology asks the question, what does it look like? Pathophysiology asks, why does it look like that? How is it changing? What caused this, etc. Okay? So let me write those things down real quick. So when we're talking about how something looks, we're talking about the anatomy of it, right? The structure, what it looks like, the shape. Whereas over here, what do we have? The physiology, right? All of these things come into the physiology, which obviously you may have taken a class before called anatomy and physiology. Well, now we're just applying that to disease. We're understanding the physiology of disease. And we can never talk about anatomy and physiology unless we understand the term homeostasis. Remember, homeostasis is basically the ability of your body to maintain an internal set of stable conditions. So you have things like blood sugar, right? Body temperature, blood pressure. These are all homeostatic variables we need to keep in a set range. As an example, body temperature. You've got to stay around 98 degrees Fahrenheit. Your blood pressure should be 120 over 80 millimeters of mercury, etc., right? But if we have a disease, right, if we're suffering, most of the time it's going to bother some aspect of homeostasis. In fact, the very definition of disease is the absence or inability to maintain homeostasis. And you probably knew that, right? Like when you're like sitting at home with a cold and you're not feeling very well, obviously you can't do normal things. You have a fever, you're sweating a lot, right? These are all things that are disrupting your homeostasis. Now, obviously your body eventually fights off most diseases that you get. That is because of a term called allostasis. Let's write that one down, allostasis. This is basically saying, hey, if you have a problem in your body is going to go to that area that's causing you the disease and hopefully be able to fix it so that you can get back to homeostasis. So allostasis is basically the process by which we return to homeostasis. Now that being said, are all diseases made equal? No, all diseases are very different, right? Like cancer versus a common cold, those are two very different. One of them, the common cold, we can do allostasis within our body, fight it off. But cancer, we usually have to get some treatment options in. And we can honestly relate your body to kind of like a computer system, right? If a virus enters your computer system, a lot of the times you have some sort of firewall or protection that can block that virus, reset the computer, and therefore the computer is free of the virus. But sometimes that virus gets in, installs some malware, some freaky stuff, and then you got to get an IT guy in to come and fix it, right? So there's these different levels of severity in terms of diseases and if your body can fight it off via allostasis or not. So as we mentioned, common cold, cancer, there's a lot of different types of diseases. So what exactly causes disease? Okay, so this is where the teacher in me comes out, if it hasn't already. What causes disease? I'm going to give you 3 examples, and you're actually going to have to predict what the classification is. Now, before we do that, what the fancy term is for what causes disease is something called etiology. Etiology. This is the study of the cause of disease. Very similar to etymology, basically the study of how words came about. Now, for these 3 examples, I'm going to write them down. You've probably heard of several of them before. For the first one, HIV. You may have heard of that before. The second one I'm going to say is trisomy 21, also called Down syndrome. And then the last one I'm going to write down is heat stroke. All of these are examples of some sort of disease or imbalance to homeostasis. So we're talking about pathophysiology. Where does it come from? So these are 3 very different diseases in a way, right? But what do you think would be classifying each one? Like what causes HIV? What causes Down syndrome? What causes heat stroke? Well, obviously you can say for heat stroke, it's the environment, the heat outside, right? So one classification of the etiology of disease is the environment with which you live. Have you ever said with which, right? It's kind of like which, that sandwich place. Anyway, so the environment can be a big one, right? So we learned about in Michigan, Flint, Michigan, they had lead in their water, and so all sorts of cancers and diseases were coming about. That would be an environmental cause of disease. The etiology would be the lead in the water. But trisomy 21, Down syndrome, this is actually abnormal chromosome numbers, so basically chapters of DNA in your cells. So therefore, we consider this a genetic cause. Muscular dystrophy is another one. Sickle cell anemia is a genetic disease, right? Because there's something in your genes and your DNA screwed up. Now you have this disease. Now, HIV, you've probably heard of this, right? The human immunodeficiency virus. Virus is the key, right? It's some sort of pathogen. So the last one will be a pathogen. Now, pathogen, ding, ding, ding. What do you notice about that word? Well, patho means disease or suffering again, right? Now, gen, like Genesis creation account in the Bible, that means to create or initiate. So I'm going to say to initiate. So what is a virus or a bacteria or a protozoan? They are all pathogens. They're initiating disease. Very interesting, right? So viruses, again, bacteria, protozoans, fungi, all are types of pathogens. Very interesting. So now that we know the classifications of disease, we need to be able to describe the diseases in many different ways. Many different ways. Notice, many is a great little mnemonic for the 4 kind of descriptors of certain diseases. Multifactorial, iatrogenic, nosocomial, idiopathic. Really cool names. Trust me, I'll give you a little better understanding of each one as we go through it. So multifactorial, if you think of the word multifactorial, there's many factors going on in here, right? So this is when many things cause the disease. So there's not just one thing. So I'm going to say 2 or more things cause the disease. So for example, we know that obesity is a big disease, especially in the United States. Well, is obesity caused by one thing or many things? Well, generally many things, right? So that would be considered a multifactorial disease because perhaps you're in an environment where you can't move around as much, right? You live a very sedentary lifestyle, you have an office job, but maybe your parents were obese and maybe they had some issues with metabolic syndrome. So therefore you have a propensity to obesity. There's a lot of factors that go into that. But then we have things called iatrogenic, okay? Iatrogenic diseases. Now, this one's kind of interesting. This is when actually you get treated for a disease, but then it in turn causes some other issue. Have you ever had that before? Hopefully not. So let me give you a great example of this. Have you heard of this jingle from a commercial? Oh, 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 Ozempic, you know. I don't know the rest, but have you heard of Ozempic before? That is called a GLP-1 agonist, and that is a drug that actually has a lot of good things happening, especially to lower the risk of diabetes and obesity and that type of things. However, we have noticed that a lot of the time, if you take these, you can actually get depressive symptoms, okay? There have been studies that have shown that those people who have taken these for an extended period of time had a lot of mental disorders associated with it. So therefore, we can say that is an iatrogenic disease, depression, because of the treatment for some other disease, which is kind of interesting, right? Now, the way I remember this is if you were to go to your doctor and you're having depression and you said, hey, you gave me this drug and you didn't tell me about this, or that it's causing this for me, what would their response be? Iatrogenic, right? That's kind of how I remember it. They would kind of scratch their head and say, iatrogenic. Cool. Hopefully that's helpful. My brain works in mysterious ways. Now, the third one, nosocomial. This is when you are in a hospital setting and you actually get the disease because you were in the hospital from like another patient, right? So this is really common with MRSA, okay? A type of fungus that can actually get on your skin and spread, and it makes a really nasty rash, as I'm itching my arm already. But the way I remember that this comes from a hospital setting is, where are people with comas? Generally in the hospital, and nobody wants to go there, right? Nobody wants to go to the hospital, and that's where people with comas are. So that's how you can remember nosocomial. Last one is idiopathic. This one is my favorite because it makes you feel like an idiot. This is when, right, idio, this is when you don't know the cause, no discernible cause for some disease, okay? Now, this could be as simple as, hey, I get migraines and they couldn't figure out why. That would be an idiopathic disease. We don't know what's causing it. Or it could just be something that, hey, like you have obesity, but you're eating right, you're exercising. We don't know what's causing it, okay? That could also be considered idiopathic. Okay, so now we've talked about some diseases and how they're classified, but how do we actually diagnose and figure out what disease you have? Because some of these are obvious and some of these are less obvious. So let's get into that next. So I'll be really honest with what So I'll be really honest with this one. This is probably the easiest one, right? Let's say you are at home and you're not feeling the best and you start feeling just bleh, right? You're nauseous, maybe you're throwing up. Well, in that case, you're already kind of diagnosing yourself because you have two main categories of things you're looking at. The first thing is some sort of symptom, okay? Now, what is a symptom? Well, a symptom is actually a subjective feeling. I feel nauseous. I feel uneasy, right? These are all subjective descriptions of how the patient is feeling. So subjective descriptions of feeling, okay? You can't quantify symptoms, right? You can't quantify nausea, right? You can't quantify very well pain. These are all symptoms. So let's write those in. So like pain, nausea, etc. Okay? Now, your doctor will ask you your symptoms, okay, naturally, but the more important ones are that we can see our signs. Now, signs, instead of being subjective, they are actually objective. These are more like fact-based, and they are more quantifiable. So objective, quantifiable signs of disease, okay? Now, what could this be? Well, this could be, hey, like you get a blood test done, right? And you see that your hemoglobin is like super, super low, right? And so you're anemic. Or maybe you're looking at your blood glucose levels and they're super, super high, right? So maybe you have some diabetes. So any sort of blood test you're doing will be a sign. And also anything we can just like physically observe. Like, for example, congestion. For example, if your nose is completely 100% quantifiably plugged up, it's likely you have some sort of a cold or like a upper respiratory infection, right? So these are things that we can point to and say, hey, this is some sort of sign of an underlying disease. Now, we can look at all these things, and ultimately the goal is to come up with some aspect of, obviously, a diagnosis. So all these lead to a diagnosis, hopefully, as long as it is not idiopathic. And we just call the diagnosis like the key marker for a disease. So key marker for a disease. So as an example, let me draw this real quick. If you have malaria, for example, due to the malarial parasite, your doctors will get you a blood test. They'll look at your blood cells. Here are your red blood cells. And they will actually see, hey, There are little protozoans living inside your red blood cells, and your red blood cells are starting to die. That would be the key marker for the diagnosis of malaria, right? Furthermore, let's say you get a blood test and your blood glucose levels, so blood glucose, are at, say, like 1,000 millimoles per deciliter. That would indicate that you have diabetes because the average blood glucose range is about 60 to 100, so that would lead to the diagnosis of diabetes. These are key markers that lead to a diagnosis. Wonderful. Now, with the diagnosis, now we can actually address the issue, right? So one of the first things your doctor will give you is something called a prognosis. That kind of sounds like the word progress, right? So how does something progress? Prognosis is basically the outcome of either the disease or the treatment. Basically saying, how are you going to be in some time from now? So if you have, say, a terminal cancer diagnosis, right, they may give you a prognosis of 3 months to live. Or if you come in with a common cold, they may say, hey, it'll probably go away in about 1 to 2 weeks on its own, right? Those are all prognoses. However, we also have to talk about some kind of not happy things, and that is morbidity and mortality in disease. So morbidity, if I can spell and speak at the same time, morbidity and mortality. Now, a lot of people actually in the general public use these terms interchangeably because if you say something's morbid, it's kind of like going to lead to death, and then mortality, we're mortal, we're going to die at some point, but it's actually slightly different. Morbidity refers to the disease rate, okay? So the disease rate, let me write the other one next and then I'll explain it. Whereas mortality is actually the death rate, okay? So what's different there? Well, we can say, hey, in America, and this is not an accurate estimate, there are 10 million people with cardiovascular disease. That would be the morbidity of cardiovascular disease. However, if I said, hey, about 2 million people die every year of cardiovascular disease, now we've moved into mortality rates, okay? A slight difference. The way I remember the difference is if you look at the spelling, morbid versus mortality, they go in alphabetical order, just like disease comes before death. So that's how I kind of remember those two. So I've given you a bunch of examples and words now, and now I believe it's your turn to try to figure it out yourself. So I'm going to give you a short little case study, and we're going to actually fill in all the different symptoms, signs, diagnosis, etc., so that you can practice it before we move forward. All right, forgive my poor handwriting, but I'm going to read this out to you, and we're going to point out some signs, symptoms, as well as the classification, and then talk about the diagnosis, and also what's going to lead us into a little cellular physiology here in a second. So first off, there's a 72-year-old male, comes to the hospital complaining of fatigue and swelling of his legs and ankles, and his breath is labored. He is sedentary with a family history of cardiovascular issues. Okay, so I want you to pause the video and actually think of which are signs and which are symptoms here. And then also, can we classify this disease before we even know what it is? Okay, so I see he comes to the hospital complaining of fatigue. Well, can you quantify fatigue? Not really. So that's going to be a symptom because he's feeling that way. But then we see the swelling, right, of his legs and ankles. So that is clearly a sign, right? So we know that's a sign because we can see it, quantify it. And breath is labored. That's also something we can actually identify. So therefore, we can say that is a sign, although it can also be a symptom because how labored is labored, right? Now, he's sedentary with a family history of cardiovascular issues. That tells you that there's likely a genetic component, right, family history, as well as an environmental component of what he's doing in his day-to-day life. So therefore, we could say that this is a multifactorial disease, right? Multifactorial. There's multiple things influencing it. Okay, so now we're going to continue on. The doctor gets blood work done, shows elevated A and P levels. That's called atrial natriuretic peptide. You can learn about it here, which is going to give away what this is about. But it's a hormone level, okay? And he looks at the echocardiogram, looking at his heart, and he sees cardiac hypertrophy. Okay, a lot of cool terms here. Let's break it down. A and P levels, right? This is a hormone. We see that they're elevated. They're above homeostatic range. We know that is going to be a sign, right? Elevated A and P levels. And then echocardiogram, right? We're looking at hypertrophy, big heart, right? So therefore, that is something we can see as well. It is a sign. Now, that being said, I want to point out cardiac hypertrophy in a second after I tell you what the diagnosis is. This is something called heart failure, congestive heart failure. Congestive because we're building up some fluid in the legs and also in the lungs as breath's being labored. And heart failure means that the heart can't keep up with the demands of the body, and that actually remodels the heart, making it really big, okay? Now, that being said, we've got the diagnosis. How did I arrive there? Well, we know the marker, remember the marker, the diagnosis is elevated A&P levels. If you look that up, that is the main diagnostic tool we figure out for heart failure, although these signs are also pretty indicative. Now, after we know that, the doctor treats the patient, gives him a variety of thiazides. These are a diuretic. It lets you get the fluid out of your body so that edema kind of leaves, the fluid buildup in his body. But then he experiences elevated plasma potassium levels, which is hyperkalemia, high potassium in the blood, which leads to heart palpitations. Okay, what is this? What is this? Remember, so remember, anytime the treatment leads to another disease, that is called an iatrogenic development of the heart palpitations, okay? Now, I want to come back to cardiac hypertrophy, and then I'm going to talk about hyperkalemia as we lead into the next one. The cardiac hypertrophy occurred in response to the congestive heart failure. That is something called sequela, okay? So I'm going to point to this and say sequela. This is basically a result of a disease. So since we have heart failure, over time that led to cardiac hypertrophy, okay? So whenever you see sequela, the sequence of events is you get this leads to something else. Whereas the iatrogenic aspect is your treatment leads to some other issue. All right, last but not least, that hyperkalemia. What is this? Well, this is high potassium in the blood, as I mentioned. But why does the blood matter in the first place? Why are we looking at the blood? Well, in order to figure out what's so important about that, we need to understand cell physiology so we can understand how pathophysiology works, because all disease happens at a microscopic level, or most disease for that matter. Okay, so we know disease happens on a microscopic level, but more specifically, it happens on a cellular level. Now remember, your cells are the functional workhorses of your body. If you do something, it's because your cells are doing something, and you have 30 trillion of these little workhorses, and they need things to go well for themselves. If they're not in the right environment, if they're not making the right stuff, you can have a disease. So what I want you to do is think about any one of your human cells. If this cell has one of three things go wrong, you will have some sort of pathophysiology. And in fact, all pathophysiology, all disease can usually fall under one of these three categories. Now remember P.E.D, like performance enhancing drugs, which they say performance enhancing, but they're really bad for you, so don't do them. But those are going to be the letters that start with each of the three. So the first one is going to be protein. Something's wrong with the proteins of the cell. We'll get into the details of it. The second one will be the environment. The cell is bathed in some sort of environment that's giving it some sort of disease. Or lastly, we've got D, which will be DNA, or any sort of nucleic acid issue. Nucleic acid issue. There we go. Okay, so we're going to start first with environment, okay? So what is the cell's environment? Like if you think of any one of your parts of your body, what is that cell bathed in? Well, your cells are bathed in fluid coming particularly from your bloodstream. So I'm going to draw a bloodstream here. And I want you to remember that the bloodstream goes to virtually every cell of your body, and it's a river of life. So I want you to think every cell of your body, but basically all of them, are touched by your blood. And some of the blood components will actually be able to leak out and basically surround the cell with a sort of extracellular fluid. Okay, so this is called extracellular fluid, literally translating to outside of the cell and then fluid. So whatever is in your blood is bathing your cells, okay? So think twice the next time you try to smoke or you try to vape, because everything you put into your lungs gets into your blood and your blood bathes your cells. So don't put anything in your lungs except for, air. I digress. Now, that being said, the environment of the blood can change a little, right? So in your blood, I want to just list a few things we have here. So we have electrolytes inside of here. Have you ever thought about why electrolytes are named that? It's because electrolyte, it means tiny charge. And these are things like sodium, which is written Na+, things like calcium, Ca2+, things like potassium, K+. You see how they all have a charge associated with them? These are ions. Basically, whenever you eat salt or something with calcium or potassium in it, it dissolves in the fluid of the blood, and dissolved things are usually charged things. If you want to learn more about that, you can watch this video here. That being said, we have relatively high and low amounts of these things in our blood. So for example, sodium, I'll just give you one. Sodium in your blood will have an homeostatic variable of about a 135 to 145 millimoles per deciliter, okay? So that's basically your homeostatic set point for sodium. Now let's say, for example, your sodium levels go up to 160. Well, that leads to a condition called hypernatremia. Hypernatremia, literally translating to high salt, Na, sodium, in the blood, emia, okay? Now, if you had too low, so let's say you had about 100, this will lead to, as you could probably guess, hyponatremia. Hyponatremia means low sodium in the bloodstream. Interesting, okay? Now, why is this bad? Why are your electrolyte balances important? Well, we know that in the cell, sometimes in order to do something for the cell, we need to bring in some sodium. So let's say there's a little protein channel here, and it's allowing that sodium in, and sometimes when the sodium in it comes into the cell, it does some sort of action, okay, for the cell. For example, in your heart, when sodium comes into the heart muscle cells, it actually triggers the heart to contract and beat, right? But if you had way too much or way too little, that action can get screwed up if you have the wrong homeostatic variables, okay? So if you're too high or you're too low. That's what I was talking about earlier with hyper and hypokalemia, meaning potassium levels. All of these things need to be at the proper set point in order to maintain normal health. And if you don't have that normal health, you obviously have a disease. So that'd be the pathophysiology of some electrolyte issues. Now we can have other things in the environment that can be off as well. Could be potentially fluid amount, right? Just water amount. So if you are dehydrated, you have hypovolemia, you have very low fluid in your blood, that could be an issue as well. And it could also be nutrients, right? So in the bloodstream, we'll have nutrients like, I'll draw them in a different color, like amino acids and glucose. So amino acids build your protein. So these are the base unit of proteins. Your glucose is usually for energy usage, so ATP, energy made in the cell, needs glucose. And if you have too high or too low of this, obviously you could have a disease. So let me give you an example. Let's say you have too high of blood glucose or too low. You could have something called hyper or hypoglycemia. What does that mean? High or low sugar glyce in the blood. Glucose is a sugar, high or low is a bad thing. For example, if you are diabetic, you have something called hyperglycemia, where you generally have high levels of glucose. And a lot of the times, if you have high levels of glucose, you're going to be peeing a lot. You might have an issue with a ketoacidosis, where you're actually transitioning to making fat or using fat for energy rather than glucose. So I know this is a lot, but just clarify, right? Nutrients, stuff in the blood, fluid, electrolytes, these are all good things. And if we have too much of a good thing, it's a bad thing. If you have too little of a good thing, it's also a bad thing, right? So we have to have that happy middle. But there are some just bad things that can get into the blood that we don't like. For example, let's say you have a disease called tetanus, right? You have the tetanus toxin inside of you because of a bacteria. So let's say we have the tetanus toxin inside of your bloodstream. Well, the tetanus toxin, right, came from a bacteria, and that bacteria is producing that tetanus toxin, throwing it into your bloodstream. Well, obviously that is an incredibly bad thing that is now bathing your cells. And in fact, that tetanus toxin can come in and bind to certain cell receptors, specifically in your muscle cells, and actually stimulate your muscles to be super, super contracted, and that's what causes tetanus, lockjaw, where your muscles are locked tight. So that is based on the environment of the blood, the toxin that's in it from the tetanus bacteria, therefore causing some sort of pathophysiology to your muscle cells in particular. Okay, wonderful. One last thing I want to touch on with environment is pH. So pH basically just means acidity. Okay, I've got a lot of videos of acidity on this channel that you can watch, but generally speaking, your blood pH needs to be from 7.35 to 7.45. If you are too low, say you're below 7.35, you have something called acidosis. Your blood is too acidic. And if you're above 7.45, you have something called alkalosis, where your blood is too alkaline. Now, why are these issues? Why are these bad? Well, we know that proteins, so basically the structure and function of your cells, which we'll talk about here in a second, I'll write that here, need to be in a particular pH. So proteins work at a proper pH. So if they get out of that range, say we're too high or too low, we can actually have proteins denaturing at the wrong pH, at wrong pH. What does denature mean? Well, you lose your nature, you lose your structure. So if the protein loses its structure, obviously it loses its function, right? Makes sense. So what's interesting, for example, I drew a protein channel right here, right? This is a sodium channel, allowed sodium into the cell. If that protein channel were to have the wrong pH, gets all screwed up, now it doesn't shape right. So maybe it'll denature, look more like this. Well, now hypothetically, would the sodium be able to get in? No, because the protein is not structured properly anymore because of the wrong pH. Okay, so that's why alkalosis, acidosis, either one can be very, very dangerous due to denaturing proteins. Very cool. Well, not cool. Obviously, disease is bad. Now, moving on, let's talk about proteins a little bit, but we can't talk about proteins without DNA. We know that all proteins of your cell, so say it's a protein channel, this is a little receptor here that we've talked about a little bit ago. All of these membrane proteins, we can have other things, came from the DNA. So the DNA will read itself, we'll go through the details here in a second, and create these proteins. Now, the problem is sometimes these proteins can become denatured, not based on any other pathology. For example, we have a disease called Alzheimer's disease. Alzheimer's disease, where there's some sort of protein called a prion protein that gets misshaped, and it actually leads to obviously death of several different parts of the brain tissue. So that's all due to a misfolded protein. Okay, so misfolded proteins are not good. Now, how else can proteins be an issue with pathophysiology? Well, I talked about receptor proteins before, right? Well, in some cells, we have certain receptors. Let's just say, for example, the ACE2 receptor. This is found primarily in your nose, your olfactory epithelium. It's also found in some blood vessels. Okay, it's also found in the lungs. So these cells of your body, in the nose, blood vessels, and lungs, express this protein, ACE2 protein, and it looks like kind of a receptor, right? So it's going to receive some sort of information. We won't talk about what. But the problem with this protein in a way, is that the COVID-19 virus will look something like this. So this is COVID-19, we'll say. You may have heard of it before. It's not like there was a pandemic within the last 5-6 years. So this is COVID-19. And this COVID-19 expresses an antigen, that's basically this little flag on the outside of it. And that antigen, as I drew, fits perfectly into that ACE2 receptor. So COVID actually uses this receptor as kind of a docking site, kind of like a key into a lock, so that COVID can then enter into the cell and wreak all sorts of havoc, okay? So that's how a normal functioning protein of your body can actually give rise to infection. There's actually been studies lately that people who underexpress, don't make this as much, don't get COVID as often or as bad. But people who have a lot of these receptors, a lot of these proteins, they actually have a bad infection. Makes sense, right? The more locks to allow that key in, the more COVID you will get. We'll give an example with HIV here in a little bit so we can talk about the specifics of the pathophysiology of viruses. Now, one last thing with proteins, so I'll jot down viral entry here. One last thing with proteins is actually antibodies. Okay, antibody issues. Now, if you don't know anatomy physiology that well, let me give you a brief rundown. In your bloodstream, you will have these cells. They are amazing cells, absolutely amazing cells. These are called lymphocytes, okay, because they like to live in your lymphatic system. And specifically in your lymphocytes, there's two classes. There's T and B cells. And we're going to say this is a B cell. This B cell is amazing in that it can learn how to produce proteins called antibodies. So I'm going to draw these little guys, and I'm going to label these as antibodies. Now, normally, they are anti a body in a way. What bodies? All the pathogens, right? So if you get infected with, say, COVID-19 that I drew here, you see that the COVID-19 has an antigen in a little identification marker that the antibodies can then attach to. So let's say this lymphocyte finds COVID-19, attaches its antibodies to it, it will actually be able to neutralize this. So antibodies generally can fight infection. That is wonderful. So obviously that's fighting the infection, that's a good thing, but I'm saying that it's actually leading to pathophysiology, leading to disease. How? Well, sometimes these B cells and also your T cells, so both lymphocytes, they can get a little stupid. They can get a little stupid. Sometimes these lymphocytes can actually make antibodies for your own cells. So these antibodies sometimes attack your own cells, or I'm just going to say cells. Now that's a bad thing. That's a very bad thing because now these are going to start destroying your own cells. So as an example, let's say that this is a beta cell of the pancreas. Let me just draw it like right here. I'll draw this as a beta cell. Okay, this is beta cell. And this lies in your pancreas. And normally this beta cell will actually produce the hormone insulin. So I'm going to draw insulin as a little circle. This is insulin. And that helps lower your blood sugar, right? So we may have learned about that. So beta cell in your pancreas makes insulin to lower that blood sugar back down after a meal. But sometimes your lymphocytes can get angry at the beta cells. Why? We don't actually know. But what we do know is that the beta cells sometimes just have an identification marker, once again, an antigen here. And this is a self-antigen. This is basically an antigen that says, hey, I'm a human. I'm a human cell, so don't hurt me. But does the lymphocyte care sometimes? No, sometimes it makes antibodies that will actually attack yourself. And you will begin destroying your beta cells of your pancreas, right? So if this lymphocyte attacks pancreas beta cell, what do we not produce? We do not produce insulin. That pathophysiology is called a type 1 diabetes. It is an autoimmune disease where your lymphocytes, for some reason or another, could be genetic, could be environmental, we don't know, attack the beta cells, thus leading to type 1 diabetes. Okay, type 2 is a little different, but that's just type 1. So once again, this is all due to some sort of issue with proteins, right? We're making the wrong antibody proteins attacking your own cells, triggering pathophysiology. Very cool. Again, not cool, but it's fascinating. And by the way, if this has been helpful so far, please consider liking the video, subscribing to the channel. Really appreciate your support. Okay, so now that we've talked about proteins, let's talk about the genetic code that actually codes for those proteins, and that's going to be DNA. DNA is stored in your cell's nucleus, and as I said, we're going to read this DNA and produce those proteins like the membrane proteins, like the antibodies for those lymphocytes. But we're going to talk about two specific kind of diseases, pathophysiology, in cancer as well as genetic disorders. So we're going to talk about cancer, then we're going to talk about some genetic diseases or genetic disorders. And the reason I'm going to talk about those two is because they're going to come up a lot, both in a pathophysiology course, but also in clinical settings. Now, in order to figure out what's going on here, we need to know a few things. Number one, you get your DNA from your parents. So you inherit your DNA from your parents. Okay, you may have known that already, right? Maybe you did a Punnett square back in biology class. Maybe you blacked it out because you hated that section of the course, but I loved Punnett squares. So you get this genetic code from your parents. It can either be good most of the time, or sometimes you can get some bad stuff. So let's talk about what happens when you just inherit good, normal DNA that code for the proper proteins. So let's first talk about cancer. Now, in order to talk about cancer, we need to know what the cell does normally so that we can understand what happens in the pathophysiology of cancer. So normally, what the cell will do, I'm going to say normally, cells produce proteins that tell them when to divide, okay? Now, this is most common in cells called epithelial cells, so the cells lining your body, things like your skin cells, things like your esophageal cells, all those cells. Now, in order to divide, they need proteins, right? And we make the proteins from our DNA. Now, in our DNA, the proteins that tell the cells when to divide are the following three. The first one is going to be called I'm going to do it in red, a proto-oncogene. Proto-oncogene. Okay. The second one will be something called a tumor suppressor gene, and then a DNA repair gene. DNA repair gene. Oh my goodness. We're learning a lot today, but you're going to enjoy this. So check it out. First off, I want you to think of the proto-oncogene as going to basically speed up division. Speed up division. It's going to be the gene that codes for a protein. So again, gene codes for a protein. So we're going to draw that here. So this is the gene, the proto-oncogene. I'm just going to label this as P. It's going to produce, here's a little cell biology overview for you, a strand of mRNA that's going to go to a ribosome. We'll just draw the ribosome as like a little, I don't know, a little dot. And that will code, again, for a protein. That protein is going to tell the cell to divide. Okay, it's going to tell the cell to divide. So let's say in your skin, you've got those stem cells in your skin basically making these proto-oncogenes, making the proteins that tell the cell to divide. Now, normally functioning, that's a good thing. But what if, for example, the cell got screwed up somehow, right? Maybe the DNA got damaged, or maybe some proteins aren't looking good. Well, you don't need that divide protein to be there. You want to actually slow down that process, or maybe even trigger some cell death, okay, so that the cell doesn't screw up other things. So therefore, you also have these genes called tumor suppressor genes. I'm going to label these as TSG. They will once again code for mRNA. That will go to a protein, and we're going to have that protein be like a yield sign, right? We're going to slow down division, okay? So tumor suppressor genes are actually going to slow down cell division. Now, why is it called a tumor suppressor gene then? Well, think about it. A tumor is a growth of a lot of cells, right? So if we use a tumor suppressor gene, we're not going to have that cell divide as often. Therefore, it's going to suppress the chance that we would get a tumor, okay? So for example, rather than going from like one cell to like 5,000 cells, we're instead going to turn that tumor suppressor gene on and maybe just keep that cell by itself, okay? Very cool. Now the last one, as it probably makes sense, is a DNA repair gene. So I'm going to label this as DNA repair gene, DRG. And obviously, you can probably guess, this is going to code for an mRNA. It's going to code for a protein. It's actually going to go back into the nucleus, and it's going to repair broken DNA, broken or damaged DNA. Now, think about that. Let's say, for example, this proto-oncogene just got broken, right? So maybe we have some damage here. If we damage that, we could run the risk of this cell just dividing like crazy, right? So instead, we've got these DNA repair genes that will go back in, notice that damage, and repair it on the spot. So think about this. It's kind of like it's kind of like a car going on the road, right? So you're driving, you're going, you're dividing, but then your car breaks down, right? Your car breaks down. So the tumor suppressor gene will then be activated. You'll pump the brakes, right? You'll pump the brakes and maybe you see a mechanic on the side, right? So you go to the mechanic, you stop, and then you repair that information, right? You repair your car. From there, once you repair the car, maybe the cell can go on and divide again and you can get back on the road. But what if you heard that like kind of clunking going on in your car, right? Because your proto-oncogene was damaged, but you decide not to slow it down. Well, what if your car maybe goes into like full-on acceleration, you can't stop it, like ripping the brakes out of your car? Well, now that's going to continue to divide the cell, You're going to keep driving, and you could cause a lot of damage. Now, why am I mentioning that? Because if you damage any one of these three, you damage the accelerator, you damage the brakes, or you damage the mechanic, all three of these, if you get them damaged, could cause cancer. Okay, so I'm going to label over here damage to these or messed up these could lead to cancer. Why? What is cancer? I'm going to erase this COVID-19 word here. What is cancer? Well, cancer is rapid, unregulated cell growth and division. So basically causing a mass, a tumor of a bunch of cells that are really big and very plentiful, right? And that is cancer. Now that's bad because you don't want that. You don't want a tumor because it can invade other places of your body and cause a whole lot of organ damage. So we don't want that. So that's why we have these genes, right? To kind of modulate cell division. However, as I just mentioned, if they get messed up, you can get cancer. How can they get messed up then? Well, number one, could be an environmental thing, right? What if you get bombarded with toxins like alcohol for a while? Well, alcohol can damage DNA, increases your risk of getting cancer. The second main way, besides environmental, is actually inheriting bad genes from your parents, okay? A couple bad genes that you can actually inherit from your parents are the following. You may have heard of them before. One of them is called a BRCA gene, BRCA. There's BRCA1 and there's BRCA2. There's also a P53 gene. Both of these are tumor suppressor genes in and of themselves. When they're working properly, they do great. However, certain people actually have bad BRCA genes and bad P53 genes that they can then pass on to their children. Now, why is this a problem? Well, if you inherit these and they are actually bad, they're mutated is the technical word for it, they increase your cancer risk. They increase your cancer risk. Why? Because it's as if you are taking away the opportunity to slow down your cell division. If you can't slow down your cell division, chances are your cells will continue to divide, and that could cause rapid unregulated cell growth and division, cancer. Hopefully that makes sense. If you're having any questions on this, please drop in the comments below. And I've also made a few other videos on cancer and other genetic disorders that you can check out on my channel. Okay, so that is cancer, but I also wanted to talk about other genetic disorders, right? It is very similar, genetic disorders, to if you inherit a bad gene from your parents. So for example, there is a disease called sickle cell anemia. Well, sickle cell anemia, I'm not pointing to this. Sickle cell anemia is when you have a messed up hemoglobin gene, okay? So sickle cell anemia is caused by a mutated gene. All right, what's going on there? Well, hemoglobin ends in IN, it's a protein, and the gene is the DNA sequence that codes for that hemoglobin. Now, hemoglobin actually builds your red blood cells. So in your blood, you've got red blood cells made of hemoglobin, like they're just packed full of them. But if you have a mutated gene that you received from your parents, well, now you can't make the protein properly. Can't make the protein properly, can't make the cell properly. And now we're going to turn these red blood cells into these sickle-shaped red blood cells. Now that's a problem because then these can form clots, they can cause strokes because they'll plug up blood vessels, a whole slew of bad things. That is a type of genetic disorder because you inherited a bad gene or genes from your parents. Now, there's other genetic disorders dealing with chromosomal abnormalities like trisomy 21, Down syndrome. That's when you inherit an extra chromosome 21. Okay, you can learn more about that here. Okay, so we've talked about DNA issues, protein issues, and environmental issues, but I want to zoom in specifically on these viruses, right? Viral entry. That's going to be a big topic in any pathophysiology class. So what I'm going to do is take a case study of HIV and show the process through the cell in order to actually have that HIV propagate and divide. But I'm also going to show little sites where we can use medications to actually stop HIV from spreading and thus hopefully prolong the person's life that actually has HIV. So to make this process easier, I want you to imagine a kid who's been eating cornflakes his whole life, but realizes that Frosted Flakes are the best thing in the world. So he goes actually to the cornflakes factory and he decides, you know what, I'm going to trick this machine. I'm going to insert some information into this factory machine to actually tell the factory to, rather than produce cornflakes, let's actually make Frosted Flakes. So let's add some sugar to it and a bunch of corn syrup, right? So what he does, he puts that information into the system, he begins putting it through the factory, and then all of a sudden, instead of cornflakes coming out, we've got Frosted Flakes coming out the wazoo like crazy. And all the factory workers are like, what the heck is going on? Hey, that's viral infection, y'all. So what's happening here? Well, eventually what's going to happen is we're going to have this HIV virus. It could be any virus. This is just one particular one. And it's got some information inside of it on how to build more HIV. So I want you to remember that the mature HIV RNA contains the information on how to build more HIV. The problem is by itself, the HIV cannot replicate itself. In fact, in order to replicate, it needs to get inside a human cell right here and actually use what we have called ribosomes. And these are going to be those protein-making factories. So it can take RNA and turn them into proteins. Okay, so once again, here's the virus, here's the human cell. Specifically, this is going to be called a CD4 lymphocyte. This is actually a helper T cell in your body. It's a white blood cell, and that's going to be the target of HIV infection. But again, we've got to get the information from HIV into the human cell and then actually produce the proteins needed to build the HIV. Now, I say proteins a lot in this video. What are the proteins? Well, we've got an antigen protein here that's going to act as the key into a lock. We've got proteases. This is an enzyme. It's going to do something later on. We've got reverse transcriptases. These are all just proteins that the HIV virus needs in order to build itself. But again, it needs to do that by getting the information into the factory, therefore making its own proteins from the human ribosome. So that's the big overarching goal. Now, as we go through this process, it's pretty complex, but I'll make it simple. I want you to start thinking, what could actually block or inhibit this process? Because we're going to talk about some drug classes later on that can actually block certain sequences of events in this viral entry process and replication so that we can actually diminish the effect of HIV. So let's get started. First off, anytime something wants to get into the cell, it needs a key. Think of the cell as basically your house, right? You need to put a key into the lock of the house in order to open it up. So what we've got here is the antigen, basically the ID tag of the HIV molecule. That is going to fit perfectly, annoyingly, into a protein of your lymphocyte, your white blood cell. This is called a CD4 protein, okay? CD4 protein. Attached to the CD4 protein is something called the CCR5 protein. This is actually a G protein coupled receptor. Doesn't matter. It's one of the membrane proteins very common in your cells. Now, when the HIV actually attaches, I'm just going to draw it attaching here. Okay, so here's the virus attaching to it. What it will do is actually stimulate this CCR5 receptor. It'll stimulate it. Okay. Now, think of this stimulation as basically opening the door, okay? So think of stimulate as it is opening the door, because this is actually going to induce what's called endocytosis, bringing in the virus into that cell, okay? So what we're gonna do here, well, we activated CCR5, we're opening the door, we're allowing the virus in. So now all of the viral components are going to basically integrate into this cell. It's through a variety of processes. It's going to have some involution going on here, and I'm just going to draw all this going in. Okay, so we've got several different components of the virus now in the human cell. Now, let's go through one each individually. So first off, what do we have here? Well, we have the viral mRNA, right? So here's that mRNA. Now, where do you think we want this to go? Well, you would probably say, oh, well, can't it just go right into the ribosome? And can't it just immediately make viral proteins? It could, but this virus is really sneaky. It wants to have a long-term solution to the problem rather than just making a few proteins. We're actually going to integrate its nucleic acid into the human cell's DNA. So again, this is your cell, your human cell. This is the DNA of the human cell. And so this is where the virus gets really, really tricky. It is going to use something called DNA reverse transcriptase. That's going to basically take this viral mRNA and it's going to turn it into viral DNA. So we're going to draw viral DNA here. How did that happen? We had that enzyme, that reverse transcriptase. Draw it here. I'm just going to write RT. And it's going to trigger RNA turning into viral DNA. Now, why are we doing that? Well, it's because now, check this out. This is like the kid who had the instructions for the machine to put it into the cornflakes factory. We're going to then move that viral DNA through nuclear pores. It's small enough to fit through. And it's going to get into the nucleus. Now, it is in the nucleus now, but it's not actually embedded in the very code of the cell's DNA. So what are we going to do? Well, we're going to take this integrase enzyme. So remember, some of the integrase enzymes are going to come in here as well. Okay, so integrase is coming in here. And if you think of the word integrase, you're integrating something, you're inserting something into it. What's going to happen here? Well, that integrase enzyme, along with the viral DNA, is going to insert itself into the actual strand of DNA. So I'm going to show this kind of like this. So we're inserting the viral DNA into the actual code of the human genome. This is really, really tricky. So now we've got viral DNA integrated into the lymphocyte's DNA. Isn't that just so wicked? Because now that's going to remain there. That's going to stay in this lymphocyte's DNA virtually for the remainder of its lifespan. Why is that so sneaky of the HIV? Well, now what will happen is in the human, we're going to use an enzyme. Okay, I'll just draw it as a circle. This is called an RNA polymerase enzyme, which basically takes DNA and turns it into RNA. So DNA to RNA. It doesn't matter what DNA it is, as long as it's DNA, it's going to read it. So what are we going to do? Well, this RNA polymerase is going to read viral DNA. That is going to create viral mRNA that will code for all the viral proteins. Okay, so now what will happen? Well, that viral mRNA, I'm talking too fast, is going to get out. It's going to go to that ribosome, right? It is going to read that viral mRNA, and it is now going to produce all of the proteins necessary to build the virus. So now we've got those reverse transcriptases. We've got actually immature, I'm going to draw this like this, immature viral RNA. Talk about that in a second. We're also going to make our integrase enzymes. We're going to make some antigens and some membrane stuff, but I'm not going to mention that. So what have we done? Integrated DNA from HIV, made their proteins through that process, and now what's going to start happening? Well, you could probably guess, all of this is going to come together, right? It's going to come together in a little kind of vesicle-like structure. It's going to fill itself up, and then it's going to propagate. It's actually going to propel out of the cell, and now we have our virus with the antigens, with all the proteins inside of it, and also that immature RNA. So I'm just going to draw some of them. Okay. So, long process, but I'm going to show you what happens next. Last thing. We had that immature viral RNA, right? So this is immature still. Well, in order to mature the virus, what has to happen is actually this triangle that I haven't even mentioned yet, this protease. The protease is going to actually stimulate the conversion of immature to mature RNA for that HIV. So I'm going to draw an arrow here, okay, and I'm going to draw the protease, and it's going to mature the RNA. So finally, we have a fully formed, mature HIV virus with the mature RNA, with the integrases, with the new proteases, with the reverse transcriptases, and now that virus can go on and infect more cells. Isn't that crazy? Okay, now, why did I preface this whole thing with what could inhibit this process? Well, you saw several steps that occurred in order to make a new HIV virus, right? What could we block potentially? Well, let me give you a few if you couldn't think of them yourselves. The first thing we could do is we could actually block this CCR5, right? So there is a medication called a CCR5 antagonist. What is that going to do? Well, obviously, CCR5 kind of kick-started this process of actually getting the virus into the cell. If we block that process, so we cut this process off, we now don't let the virus get into the cell, right? That's awesome. So that is one medication we can use. Another one we could use is something called a post-attachment inhibitor. Post-attachment inhibitor or antagonist, you might hear either one. Now, what is this? Well, once that HIV virus attached, we know that that CCR5 protein activated and helped this process of getting the virus in. This is just another way to block this same process, okay? It inhibits a specific G protein inside the cell. I won't go into the details of it. But you see what I mean, right? If we target a certain process of the virus getting in, we can basically eliminate viral entry. Amazing. But let's say that the virus does get in. These medications don't work properly. What else could we block here? Well, we know that that viral mRNA had to turn into viral DNA, right? So what we could use is a it's actually DNA reverse transcriptase inhibitor, DRTI. I'll write that out. What does that obviously do? Well, it's going to inhibit reverse transcriptase. So now this is going to block this process. So we can't go from RNA to DNA, therefore DNA can't get into the human genome. So that is another way we could block this virus's propagation. Another one, check it out. Let's say we have all of this happening. We got the viral RNA coming out here, but then we also had integrases, right? Integrating the DNA into the human DNA, right? So we could also use things called integrase inhibitors. Integrase inhibitors. Okay? So what that will do is block this process of getting viral DNA into the human DNA. So that can also work as a block. Last one, and there are others, but I'm just mentioning 5 of the main ones, is a protease inhibitor. So I'm going to write protease inhibitor here. As I mentioned earlier, the protease helps to mature the immature RNA of the virus to mature RNA of the virus. So therefore, if we block this process, we can't mature. Even though the virus got in, inserted DNA, all this stuff, we can now block itself from maturing, right? So that can also block HIV's kind of replication process because you can't have a mature virus. Okay, that is why when you treat something like HIV or other viruses, you are targeting some aspect of its entry and propagation. And that's also why they call a HIV drug a cocktail, because you actually take a variety of different ones to help suppress this virus's entry and replication. Very fascinating. Now, I know that was a lot, but viruses do the same thing over and over again. So if you can understand this entry process, it'll help you a lot in your studies.